Right now, we have about 6.4 billion people on the face of the earth that live in low and middle income countries, for which less than 2% have had any access to vaccine. Where that's occurring, we are seeing major activity with Delta, surpassing any peak we've seen. South Africa right now has just hit the highest peak that any country's hit, period, since the beginning of the pandemic in terms of cases, deaths, and hospitalizations. Tunisia's healthcare system has crashed. We're seeing, even today as we speak on the Olympics, the highest number of cases reported in Tokyo since the pandemic began. We're seeing that throughout the world. So what's happening is this virus is, in a sense, almost rotating around the world in a non-predicted way, meaning which country is going to be the next one to get hit. Iran right now is in its 5th surge it's had, the worst one so far. So from that standpoint, if you look at what's happening throughout much of the world, it is at the very peak of the pandemic activity we've seen to date. If you're in the countries that are vaccinated or have access to a substantial vaccine, we're still seeing a major problem. Right now, we have more people hospitalized in ICUs in Florida, Mississippi, and Louisiana than we had at any time in the pandemic to date. If you look at what's happening in all 50 states in the country right now, we're seeing sizable increases in cases. And in fact, if you look, 30 states right now have had over 100% increase in cases in the last 14 days. This is largely among those 100 million people in the United States that have not gotten vaccinated yet, 100 million people. These are also people who have not been previously infected, so they have no residual protection. That's a lot of human wood for this coronavirus forest fire to burn. And so we're going to see marked activity here. Those who predicted no summertime peak, it would be a fall winter peak, I'm afraid you're unfortunately off. This is a summer peak. Why we didn't see more of a peak activity with B117 in April, we don't know. It was Michigan and Minnesota, but this one is for real. It's hitting all of us. And it's hitting England right now on Saturday. England reported 55,000 new cases. They are even have higher vaccination rates than we do. If we had extrapolated that 55,000 to the United States based on population, that would have been about 225,000 cases a day in the US. They're ahead of us by 6 weeks, maybe 4 weeks. We surely have every reason to believe right now we're going to see what's happened in England, what's happened in the Netherlands, what's happened in other highly vaccinated countries here over the course of the next several months.
And England just opened up.
Freedom Day today is probably the most counterproductive, absolutely inane step that anybody could take. It was on the books. They had it planned already, so they weren't going to back down. As you know, their prime minister's in quarantine right now. You know, their health secretary has been infected. You're watching what it's doing this morning in the Olympics. Here we are watching new people literally almost by the hour become documented as having been infected or in quarantine. So I think, you know, we are in a very difficult state right now with this pandemic. The good news is we do have effective vaccines. The bad news is we don't have them for the world. And even when we do have them, we have a sizable number of people who refuse to get them.
So when we say infected, right, I mean, if you are vaccinated, the chances of you going into the hospital and dying seem to be incredibly low. Is that correct?
Well, let me put one qualifier on. It's incredibly low if you're not an elderly person or possibly certain immune deficiency conditions, okay? If you're someone who is elderly, who might be in long-term care, frail, it still is highly protective, but not as good. So where we've seen the real serious illnesses and the deaths have been in vaccine recipients have been primarily in that same group that we see influenza vaccine failures and deaths. But so on a whole, let me just affirm you're absolutely right. The vaccines have been really remarkable. You know, we're still working more on understanding what the one-dose J&J vaccine does. I think we'll be getting more updates on that in the near term. But at least with the mRNA vaccines, it's been remarkable.
Is there any difference between that is discernible in that regard in terms of Moderna and Pfizer when we talk about those vaccines in terms of infection rate with, and we're really basically talking about the Delta variant, right? Because to the extent that there's any breakthrough infections on the wildfire or the
Wild type, right?
the wild type or the other variant. Those are so small that
it's Delta right now. Delta is the 1,200-pound gorilla in the corner. That's the one.
Is there any difference, or do we have enough data to tell that Moderna is slightly more effective against it, or no, we don't.
No, we don't. But to your point earlier, Sam, you raised a very good point about what do we know about Delta. These variants, again, remember, are just mutated viruses that, until last November, we thought that these variants among the strains of COVID were just like talking about the same car, except one's blue, one's red, one's green, one's yellow. It really didn't make any difference how they ran or how they felt. Well, in November, we realized, wait a minute, there are three buckets here of concern about these variants that are really important. One, are they more infectious, as you pointed out? Number two, do they cause more severe illness? And number three, do they in fact actually have advantages to evade the immune protection from either vaccine or from natural infection? Well, with Delta, we know this is much more infectious. Alpha was the one that was really infectious. Well, this is at least 40 to 60% more infectious than Alpha was. This puts what we call the R naught or the RT, this reproductive number, how many people on average will one person infect. We were concerned at 1.5 and 2, meaning for every person, if you infected 2 people, the cases were doubling every 5 to 7 days. This one may be as high as 8. And this is a very certain. Now, to understand that, there was a paper from China that came out last week that was really a very remarkable piece of work where they followed people very closely after exposure to infected individuals, and actually were taking throat swabs, etc., determining what their status was. They found that they actually started shedding the virus with Delta up to a day earlier than it was with other strains. But more importantly, they found up to 1,000 times the amount of virus in the throats and respiratory tract of people with Delta than the other strains. So this can explain why, somebody basically could be much more infectious and cause that transmission. So that's why today when I say, if you are someone who's not been vaccinated, or you're someone who has just decided I'm done with it, this virus will find you.
Well, how connected that is that to then the unvaccinated, right? The metastasizing of the virus, the creation of new variants. I mean, I know it is connected, but how much of that is just a direct impact of lack of vaccination?
Yeah, well, Emma, that's a really important question. And I guess it's kind of a perspective piece. What I mean by that is I'm looking here at 330 million Americans with 100 million are not yet vaccinated. Surely when you get infected, every time this virus reproduces, it lends itself to new variants. It doesn't reproduce well, and many of the mistakes it makes are actually fatal to the virus or less likely to make it more harmful. But a few of them are just the opposite, which we're concerned about. But when I put the perspective of the high-income countries with vaccine, and I look at our 100 million not vaccinated compared to the 6.4 billion in the low and middle income countries, right now that's where the fight's at. That's where the whole issue of variant development is really at its worst. And so, I surely don't want to see variants develop in the United States or any other country with these vaccines, but I absolutely know the major variant pressure is going to come from low-income countries that God knows when they're going to get vaccine in the future.
That's an important point to keep in mind, and I want to circle back on those efforts, like what it's going to take in terms of the vaccination. But just to get back, so the Delta replicates at a much faster rate within the body. Is that mitigated by the vaccination? And if it is mitigated by a vaccination, does it also make it harder for a vaccinated person to pass it on?
Yeah, so let me just clarify one thing, because you raised a very important point. It's not that the virus is replicating faster, it's just more of it. It starts showing up sooner, but again, not necessarily because it's in fact reproducing itself faster. It's like if a human gestation went from 9 months to 4 months, that's not what's happening, okay? You just have somebody who's putting out triplets and quadruplets and whatever, okay? And in this case, The vaccines that we have, particularly the mRNA vaccines, the AstraZeneca vaccine, all appear to do a really good job against the Delta variant if, in fact, you have both doses. If you have one dose, you still get protection against serious illness, hospitalization, and death, but not nearly as good as getting both doses. Again, the question still remains about how well does the single dose J&J vaccine work, and we're still trying to collect that kind of information.
Okay, and so does it make it easier? Does it make it harder to pass on? Like,
Yeah. In fact, if you prevent something from occurring, you can't pass it on. So meaning that if, in fact, I don't get infected, then I'm not infectious. And so that's the big piece. So you're right. This is what can help drop transmission. The more people that are vaccinated, think of it like rods in a reaction. This case, it's a virus reaction. And the more immune people we put into that reaction, the less there's going to be. And so you're right. This is what's helpful, getting vaccinated.
But I'm not even talking on necessarily a population level. I'm talking in terms of if I happen to get a breakthrough infection having had 2 shots, does it diminish my versus
yeah, I got you.
Versus somebody who hasn't gotten shot? Am I less likely to pass it on because the nature of my infection is not as strong? Because I'm not going to get hospitalized. I'm not going to go. I'm not going to get. I'm not going to get. I'm not going to die. Statistically speaking.
Yeah.
Does that mean that I also have less of ability to pass it on? Is my R not lower than a non-vaccinated person's R not?
We're going to make an epidemiologist out of you yet.
I'm working on it.
I know, that's good. That's good. No, you're absolutely right. That's exactly the case. Is that when we look at studies that have tried to understand how often does somebody who's fully vaccinated, once they do have a breakthrough infection, remember, a vaccine is 95% effective if you give millions and millions of doses and you have lots of infections, you're still going to get some people who have breakthroughs. But in this case, it is actually exactly as you said. It actually does reduce dramatically your ability to transmit it on if you should have a breakthrough infection.
Okay, so that's good because, many of us have young children who can't be vaccinated, and
Absolutely.
The last thing you want to do is give your kid COVID.
That's right.
And young kids with the Delta variant, do we know that are they more likely to get hospitalized than they were with the wild type if they do get infected?
Well, you hit on this point earlier, and I didn't really address it about, are we seeing more severe illness with Delta? And it's really unclear at this point. Clearly, we're seeing very ill people, but at a somewhat lower rate than we did before. And why is that? Because the most severe cases were in those 60, 65 years of age and older. And that's the group we've really vaccinated. As much as we have holes in vaccination, that's the one area we've done better. Now, we're still far below what they've done in England, but that gives you some sense. So to go back to kids, though, one of the challenges we have right now, and this is where I have a bone to pick with the CDC about the report that they put out several weeks ago, indicating that, in fact, there was limited transmission to and by kids in the school setting, and you could probably be as close as 3 feet apart. There's a real problem with that report, and that is almost all the data collected and used in that came from the first 8 months of the pandemic. During that time, that was true. We didn't see really very efficient transmission to and by kids. We didn't see nearly as many severe illnesses in those kids. But once the Alpha variant first arose, that B117 last January, things began to change dramatically. Now with Delta, you've been watching the news and seeing all these camp outbreaks that are occurring right now. We are seeing kids getting infected, transmitting the virus, and being hospitalized. Fortunately, it's still less than we see for adults, but it is still a problem. The other thing that's turning out to be a challenge is that we're seeing potentially up to 20% of kids going on and developing this long COVID condition, which is a real concern.
That is one of the questions that was asked. If I am a vaccinated person, and obviously we're seeing 20% of kids who are infected having long COVID symptoms is very scary, I think. If you are vaccinated and you are infected, do we have any data yet on your, because I've actually known some people, or, first or second hand, who have who have gotten infected and with the vaccine, and they don't go to the hospital. They you know, it's like sort of like having the flu for a couple of days. It wasn't pleasant, but it wasn't. But how much more of a propensity do you have to get long COVID, be a long hauler, as they call it, if you are vaccinated with the Delta? Do we have enough data on that?
We don't really have enough data. But again, what we are looking at is you surely have less severe symptoms, and the number of different signs and symptoms you have is less. And that has been correlated with the likelihood of getting long COVID. So, you know, we need to get more information on that. But right now, what information we do have would support that the vaccines do reduce the number of people also who, if they do have breakthroughs, go on and develop long COVID.
I imagine saying the name Alex Berenson is probably one of the most offensive things I could say to you. But he was just on Tucker Carlson last night saying masks are ineffective and they're largely symbolic. A, is that true? B, is there value wearing a mask? If I'm vaccinated and I'm going to go into like the hardware store, I understand it. You know, it may be put aside, like it puts people at rest, or it signals that I'm taking it seriously. But is that just like one more piece of Swiss cheese that I'm putting in front of my face, essentially, that says like, you know what, I could actually mitigate the viral load I get, and being vaccinated, I could actually prevent myself from even a breakthrough infection.
Yeah.
Is that possible?
Well, you know, this is not a simple one-word answer, and that's what everybody wants today. They don't want nuance. They want either yes or no. Are you for it or are you against it? And I think what we've done is a very poor job of educating the public about how to use cloth face coverings, for example, which people label as masks. Masks are all very different from that piece of cloth that fits over your face, if you even include it over your nose, all the way to what we call N95 respirators, or actual masks that most people call, but are very, very different in their effectiveness and how they work. And, you know, there's a group, ACGIH, which is a group that was originally government industrial hygienists, have now opened up to all comers industrial hygiene. These are the people who really have the expertise to look at how does respiratory protection work? What are the devices? These are the people that are constantly learning about that. And they've actually put out data based on the CDC's original estimate that you could get infected within 15 minutes of being in a room. So imagine, instead of a virus excreting somebody, imagine you walk in a room, somebody's smoking, because that's an aerosol. That's what creates these very fine particles that float in the air. So if you can breathe that air in and smell that smoke, then you know you're also, if that were an infected person, you'd be basically getting a dose. Well, CDC has determined that if about 15 minutes, that's enough time for the concentration of virus in the air to inhale it in to get what we call an infectious dose, okay? The group that I just referred to, this ACGIH, have actually put out a document, the time to infectious dose for someone not infected with COVID or someone infected with COVID. If I'm in a room, and as I pointed out, 15 minutes, I'm done, okay? If I'm in a room and I put a face cloth covering on, just a loose face cloth covering, I'm basically infected within 20 additional minutes. If I have a surgical mask on, I get 30 additional minutes. If I have an N95 respirator on, I can get up to 25 hours of protection. And so one of the challenges we've had is we've done a very poor job of educating the public. And there was at one time when these N95 respirators you can get at any hardware store today, et cetera, were in short supply for our healthcare. Today, that's not the case. So when I talk about masks, I hate that term because it's like talking about broadcasters. And we all know, Sam, there are a lot of broadcasters just not up to you. You know, they're just not up to snuff.
Right.
Don't pat his ego, please.
Oh, Emma, you too. Okay. So anyway, but the bottom line is that, you know, we've been doing a survey at our center where we actually freeze frames of news media coverage of public events. Go look at who's wearing a mask. Up to 25% of them wear it underneath their nose. That's like fixing 3 of the 5 screen doors in your submarine. Okay. Right. I mean, what good is that? And so one of the challenges is if I have an N95 respirator on, I get some real protection, okay? If I just call it a mask and slap a piece of cloth on my face, I still get, another 20 minutes of protection in that environment. But if I'm there all day, I still get infected. And so our job has to be to educate the public. Don't just call it a mask or a mask mandate. Get the highest quality protection you can. And to me, that's why I still recommend them. It's like a seatbelt. If you're only getting a waist wound seatbelt, what protection do you get? You get some. You don't fly out of the car. But if I have a complete harness strap, I have a collapsible body, I have airbags, I have shard glass that doesn't cause the sharpness to occur, I've got a computer on board that slows down my vehicle before I hit whatever I'm going to hit, those all combined make for a much safer environment. So I look at masks like vaccines itself, they're a combination. And it's the one thing that it does, just like a vaccine, you can keep from getting infected, you also, if you are infected and not knowing it, it'll reduce the amount of virus you put out. But please don't count on it to be the be all end all. The only thing we have right now is vaccines that do that.
And talking about not counting on something to be a be all end all, but I'm just curious about if there was any development in this research about blood type and the propensity to get COVID. I saw that there was some research happening. Is there anything more conclusive or trending in any direction in that area?
Early on, blood type came up several times. We've not seen anything since that time that really has developed into what I would call a firm understanding of someone's at more at risk. What we're finding with time is it's just a function of, if you're there, you'll get it. I've heard from so many people over and over again over the last 18 months, if you just did what they did in Sweden, or you just did what they did in India, or you just did what they did in X and Y, I've heard over and over again with Vietnam and so forth, but for months, we saw very few cases. And then all of a sudden, look what happened. It blew up. And what this virus is doing is it's just basically making the rounds of the earth. And some places get hit multiple times, some places don't. I don't know why India went almost 8 months with almost no activity and then became the hottest place on the earth. That's been a challenge for us to understand. I don't understand why last spring, when this B117 or Alpha variant, we call it now, landed in the United States, it didn't do what it was doing around the world. It just hit Minnesota and Michigan. Now look what's happening. Delta is hitting everywhere. So it really isn't a function as much of the host in terms of you get it or not. If you have underlying health conditions, if you're older, if you're obese or heavier, these are all risk factors for getting severe disease, but not necessarily getting disease.
Speaking of risk factors, and then I want to ask about that sort of like the lack of predictability associated with this, but in terms of risk factors, what do we now know in terms of like risk? Like initially, I think asthma, people were very concerned about asthma, but as we went on, my understanding, and please correct me if I'm wrong, asthma ended up being associated with a higher propensity. But what about diabetes seems to be very problematic, and correct me where I'm wrong here.
No, you're right. You're absolutely right. Yep.
What about Downs syndrome? Do we know if that is more associated with?
At this point, we don't have any evidence that is more associated, but you're right. And we're learning more about these. A lot of these are interacting factors. And what I mean by that is if I'm older, if I'm heavier and I have a condition, does that even put me at greater risk than if I'm younger and don't have a weight issue and then I have a condition? One of the challenges we have, of course, is one ages, one's immune system become less effective, or in some cases they're out of whack, and so you have to take medication to actually reduce your immune response, like certain kinds of arthritis, etc., which then in turn can dumb down the immune response in a positive way for your condition, but in a negative way if you get exposed to COVID. And so that's the challenge we have right now, is trying to deal with all that. But I can tell you right now, the major risk factors are age and obesity and immune compromised, immune deficient status. Those are the three primary drivers.
Okay. And so let's talk about this notion of, it seems to me that to a certain extent, people have been modeling how the pandemic is going to go by looking at 1918. And, but it's starting to feel like we're now outside of what we could learn from 1918, right? I mean,
yep.
Why why wasn't, I mean, right now it seems to me that it's quite possible, because I'm hearing about Delta Plus in Israel, which is a subset, and maybe you know something about that you can share with us. But it does feel like this concept of, you know, when we have 2% of the world vaccinated, this concept of like, it's going to keep going and there's going to be more variants, like this could last for, it feels like years. And why didn't that happen with 1918? Was it just by chance? And B, what can you tell us about this Delta Plus?
Well, first of all, when you look at the concept of a pandemic, remember that's a worldwide epidemic, basically occurring everywhere. That's why when people say the pandemic's done in the United States, whoa, wait a minute, it's a worldwide epidemic and it's occurring everywhere, and even still here. And as soon as we forget about it, it comes back here. But I think the important point is that a coronavirus, the cause of COVID-19, is just different than a flu virus. And we've really never had a coronavirus pandemic that we've ever been aware of, even in history. Everything we can trace back even well before we had the ability to test for viruses and know had the look, feel, and smell of influenza, meaning that it emerge any time of the year, would go through various surges. Some were worse than others. 1918, it was the second one that was worse. In some locations, it was a later one that was worse. But within 2 years, the 1918 flu virus settled into becoming a seasonal flu virus. Just like what happened in 1957, 1968, and we may even call in 2009. That virus first emerged H1N1 in Mexico in March, April, caused a peak here in March, April time period around the world, smaller, and then it caused a great big peak in cases in late August, September, and early October. It went away before we even had vaccine. And then eventually it morphed into seasonal flu. So right now, when we have seasonal influenza, you're often getting infected by the ancestral lineage of the 2009 pandemic strain. With this coronavirus, we don't see that yet. What has happened is it just keeps burning and burning and burning. It has not had any evidence of seasonality. Look what's happening again right now. I mean, last summer, our big peak in July in this country was the southern states driven by this. And then we had another peak again in January, again driven by the southern states. Here it is now, July, the southern states again. That's not seasonal, you know? So I think that at this point, we just don't know enough. 6 weeks ago, the two hottest spots in the earth, one was Nepal, Pakistan, and India. The other one was Uruguay, Paraguay, and Argentina. They have one thing in common. They're both at 30 degrees latitude. The difference is one's north and one's south. That's not seasonality. So I think to answer it for you, we haven't seen this become a flu-like virus yet, and I don't think we're going to.
Yeah, and I just wanted to, I know you have to go soon, quickly ask about the likelihood of booster shots. I know Pfizer's obviously pushing for it. They have a financial incentive for that. But would that make any sense in terms of curbing something like the Delta variant that's more infectious?
Yeah, I mean, in fact, this week, the Advisory Committee on Immunization Practices, an advisory group to the CDC, is taking up this very issue. And one of the things we have to look at, and the Israeli data actually gave us some hint that particularly among the older population, there may be some waning immunity. It isn't as effective, and you may need a third dose. But we're not there yet. But don't be surprised if we end up getting booster doses. Again, this is a bit of a troubling situation for me, because every time we take one of those doses and use it in a high-income country, we're taking it away from a low-income country from having any vaccine at all. There's just a limited amount that can be produced. I'm not so worried about the companies making money on this vaccine, because this is one where if they could make all the vaccine in the world they still couldn't, we wouldn't have enough. So it's in a sense a way of saying that, yes, they will make money on it, but it's not as if they're trying to corner a market. We will not have enough vaccine for years to come.
Anything that you feel that we should know before you go? I know you have a heart out here, but
yeah, I think thank you for the opportunity to talk about these issues. I just think we have to do a much better job sharing this kind of information with the public. There's a lot of people in the public that are convinced this pandemic's done. It's over with. And they don't understand it's not over with us. And I think that's the challenge we have, is how do we get through it? What are we going to do in the fall with school open? We're not going to have vaccines for kids yet. What does that mean relative to what we're finding with this new enhanced transmission in kids? How can we have these discussions without it becoming political, without it becoming angry, and just say, we're trying to just share the best science we have. We're not going to have all the information. And how do we move forward? And so, I appreciate the opportunity for venues like this where it's really very frank and very, hard questioning, but it's also just the facts. Let's stick with the facts.
And so in terms of that school, the only thing that we can do for the kids now, because they can't get vaccinated, is to make sure that as many people around them are vaccinated.
Absolutely. Couldn't have said it better. That's exactly. And, that's not a political statement. That's just reality, So anyway.
Dr. Michael Osterholm, thank you so much for your time.
Always good to
today.
talk to you. Thank you,
Really
guys.
appreciate it.
Take you later. Bye. Thank you.
Folks, there's more of what you've just saw where that came from. That's if you hit the subscribe and like button. Thank you. Really, thank you.